Welcome back to Pharmacology. Since we've already gone through hypertension medication, so let's go through congestive heart failure treatment. Always know there's two types, systolic and diastolic. Systolic, there's going to be problems with contractility. The muscle walls are going to be very thin, and there's going to be dilation of the heart. So it's going to have a low ejection fracture. There's something called S3 gallop. And it's going to be due to like ischemic heart disease, chronic hypertension, dilated cardiomyopathy, myocarditis, and in diastolic dysfunction, there's going to be a failure of relaxation. So the heart muscle is going to be really small, it's very stiff, and there's going to be a S4 gallop. We'll go through that more in pathology, but that can be due to hypertension with left ventricular hypertrophy, cardiomyopathies, fibrosis, sarcoidosis, constrictive pericarditis, valvular disease, and normal aging. So all of the cardiac failures are going to result in insufficient cardiac output, insufficient oxygenated blood, increased venous pressure, and systolic is usually found in younger patients. Diastolic is going to be found in older patients. Okay, so forward failure is going to be a reduced output, and there's two different types. The left side is going to be dilated because there's failure of the lungs. It's going to be cor pulmonale, that's what it's called. So the hypertension in the lung is going to like have a backflow into the left sided heart, and there's going to be pulmonary congestion, and it's going to manifest as pulmonary edema. The alveoli is filled with fluid, so one of the symptoms is dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. The failure of the left heart is very serious because there's low organ perfusion and hypoxia. Backwards failure, diastolic function is going to result in edema. Right-sided heart failure is going to be problems with the venous return from all the body organs except for the lungs, and there's going to be pitting edema everywhere. Thanks to the increased jugular venous pressure, so there's going to be hepatomegaly, renal failure, and peripheral edema, ascites. And cor pulmonale is heart failure due to the lungs. Signs, as always, fatigue, tachycardia, edema, cardiomegaly, and there's two different types. Stage 1, this is more like lifestyle. So stage 1, breathlessness, tiredness from having a brisk walk, a jog, or a flight of stairs. Stage 2, there's problems at rest or minimal amount of walking. Stage 3, there's palpitation and fatigue with simple tasks like just standing up and minimal walking. Stage 4, this is the problem because this is exhaustion, fatigue, and dyspnea even at rest. The NYHA class is more like structural problems. Stage 1, the structural myocardial changes. Stage 2, there's a small decrease in exercise tolerance. Stage 3, significant decrease in exercise tolerance. And stage 4 is symptoms of heart failure in rest. Compensation is going to be the activation of the sympathetic system and the renal, angiotensin, aldosterone system. So it's going to be overactive. This person is going to have high blood pressure. At first, it's pretty good. It actually compensates thanks to the Frank-Starling mechanism. So with the reduced cardiac output, there's going to be increased peripheral system pressure to increase the cardiac output. So like there's the venous constriction, and then there's going to be increased venous return, increase cardiac output. But over time, the heart's not going to be able to, like, you know, maintain this constant high pressure squeeze. So there's going to be hypertrophy. The muscle is going to get thickened and remodeling is going to occur. The Framingham criteria, the major criteria is going to be jugular venous distension, paroxysmal nocturnal dyspnea, cardiomegaly, acute pulmonary edema, S3 gallop, increased venous pressure. The minor criteria, edema, night cough, dyspnea on exertion, pleural effusion, tachycardia is a little bit rare. Well, the pleural effusion is rare, tachycardia is pretty common. A diagnosis, you need 2 major criteria or 1 major and 2 minor. Labs, ANP and BNP are going to be increased. Medications, you're going to use the ionotropes to increase the contractility of the heart, diuretics to get rid of the edema, vasodilators to bring down the peripheral blood pressure, beta blockers to do kind of like both, beta 1s to decrease the heart rate, to decrease the contractility, and to also increase the vasodilation of the vessels. You want to inhibit the remodeling, so you're going to use spironolactones, ARBs, ACE inhibitors, and beta blockers. You also antagonize aldosterone to inhibit the angiotensin system. Dapagliflozin is SGLT2 inhibitors for osmotic diuresis, and neprilysin inhibitor will inhibit the degradation of the natriuretic peptides, so ANP, BNP. So those are going to be sacubitril and valsartan. Cardiac glycosides, digoxin, is going to be used to decrease the heart rate and decrease the workload on the heart. Beta agonists, dobutamine and dopamine. PDE3 inhibitors, IMRINONE and MILRINONE. Diuretics, of course, loop diuretics, thiazides, and potassium sparing. Vasodilators, arteriolar dilators are going to be hydralazine, and venous dilators are nitrates. Ones that work on both are ACE inhibitors, ARBs, and sodium nitroprusides. This is going to be used in your hypertensive crisis. Okay, so digoxin, generally used in African American patients with persistent hypertension. For some reason, digoxin works very, very well on people from African American descent, and not so well in like Caucasian Americans. You treat heart failure and AFib with digoxin. It's dangerous because it can get concentrated in the heart and lead to toxicity very quickly, especially in Caucasian patients. However, African American patients do have a better tolerance for this drug. It increases the force of contraction by inhibiting the NAK-ATPase to increase the amount of intracellular calcium. So more calcium, more contraction. It increases the vagal discharge, but increases the sympathetic activity at toxic doses. So usually it's parasympathetic. Okay, so in toxicity cases, it can lead to bradycardia, and then from there, arrhythmia. The gastrointestinal tract is the most common site affected after the heart, so this can cause nausea, vomiting, diarrhea, and anorexia from all those effects. CNS effects, there can be vagal and chlorothiazide stimulation. There's disorientation and hallucinations that can occur, along with visual disturbance, which is the yellowed vision. It interacts with loop diuretics and thiazides, and that leads to pretty severe hypokalemia, hypercalcemia, and hypomagnesia will enhance digoxin. The potassium inhibits binding of digoxin to NAK-ATPase, so potassium-sparing diuretics actually should not be used in tandem with digoxin because they cancel each other out. Hypercalcemia should not, so thiazides should not be used with digoxin because of the increased amount of calcium. Antacids, sucralfate, which is it's a peptic ulcer inhibitor, and enzyme inducers will decrease the digoxin efficacy, so use in caution. Okay, so in overdose, you want to give potassium infusion just to inhibit the binding. In acute digoxin toxicity, you actually avoid the potassium infusion. So first line treatment, you want to give lidocaine or phenytoin to control the heart rate first, and then start a potassium infusion, and you titrate upwards. Nowadays, we can use DigiBind, which is digoxin immune FAB, which just binds directly to digoxin. Beta agonist, you will use dopamine, which is a selective beta-1 agonist, but at higher doses, it's also an alpha-1 receptor stimulator. And dopamine will work on the D1 receptors and the B1 receptors, and at even higher doses, it will also activate A1. So you can't exceed 10 micrograms per kilograms per minute in an infusion. So dopamine is it's pretty dangerous. BIPYRIDINE and MILRINONE is a PDE3 inhibitor, and those will inhibit PDE3 and increase the amount of CAMP, which leads to more phosphokinase and more calcium. So that will prevent its degradation back to AMP. So it's going to increase the myocardial contractility and the vasodilation. So smooth muscle cells are going to be relaxed, going to decrease inflammation, and it's also going to decrease remodeling. So pretty good. However, it's not stable in dextrose solution, so you do have to be mindful of the routes. Beta blockers are going to be used in stable patients, contraindicated in acute cases because of the excessive tachycardia, but they're pretty good drugs. They decrease the heart rate, decrease the amount of renin, and the cardiac remodeling. The newer vasodilators, nesiritide, will increase BMP. The adverse reaction is going to be hypotension and renal toxicity. Bosentan is an endothelin antagonist. Dapagliflozin is the SGLT2 inhibitor for heart failure with reduced ejection fraction. Sacubitril is going to be a neprilysin inhibitor, and it also inhibits natriuretic peptide degradation. So it's going to increase the amount of dilation. So how do we manage it? We want to give them a diuretic such as furosemide first, along with hydralazine and nitrates as a vasal and venodilator, dobutamine and dopamine in order to manage you want to manage the heart rate or the vasodilation. You want to give that to manage the heart rate and the blood pressure. And in the pulmonary edema, you want to be careful and just give oxygen, nitrates, furosemide, and morphine. Not in that order, but these are the medications you want to give. Chronic heart failure, basically you just want to reduce the workload of the heart. First, we want to try diet and exercise, and then we give the ACE inhibitors, the ARBs, along with the beta blockers. So you also give them any diuretics if needed. And if digoxin if AFib is present. You also add spironolactone, not with digoxin. You want to give it as a diuretic if these are not working. And you give hydralazine and isosorbide dinitrate. So all of this is really just to help the dilation, the diuretic effects, just to kind of bring down the workload of the heart. So that's it for now. Thank you for your attention and good luck studying.